Well, here's the final section of the pulmonary section, and it is tuberculosis and the PPD. Now, the PPD is the longest continuously used test in all of medicine. Before there was the EKG, before there was the CBC, before there was the chemistry, there's PPD and PPD. Yes, tuberculosis, I do see. And now, let's blame all the vulnerable risk groups. That's right, immigrants, but immigrants from countries of high endemicity. It's still the world's most common infection. And HIV positive, homeless, alcohol, immigrant healthcare workers. You're going to see it not in the general population, but it's going to be in an immigrant healthcare worker who's homeless. A homeless, alcoholic immigrant healthcare worker who's a prisoner. A homeless, alcoholic immigrant healthcare worker who's a prisoner of a nursing home is who gets tuberculosis. Remember, we are not screening the general population. School teachers in Nevada do not get tuberculosis. Motor plant workers in Detroit do not get tuberculosis. Police officers in Wisconsin do not get tuberculosis. The vast majority of it is in immigrants. 2/3 of it is in immigrants. If you subtract out all these risk groups, you have virtually no tuberculosis in the United States. So the first thing you're going to do is a person comes with fever, cough, and sputum. Fever, cough, and sputum. Yes, it's the other salsa dance. So the other thing is, just like in pneumonia, its best initial test is that chest x-ray and acid-fast stain. Now, the best initial test is not the PPD. This is the first most common wrong answer, saying doing a PPD in acutely symptomatic patients. We are not doing PPDs in acutely symptomatic patients. PPDs are to screen risk groups. And screening means asymptomatic, not symptomatic people. Neither the PPD nor the quantiferon, which is also known as the interferon gamma release assay. Oh my goodness, I got sputum and nasty things in there. And the best initial test, that stain, more tuberculosis in those upper airways, more tuberculosis there. You can't tell for sure. If you tell me that it's a HIV positive immigrant healthcare worker, then this answer is tuberculosis. So the first thing is, after you get that stain, and once the stain is positive, you start how many drugs? So 4 TB drugs. Now, here are the questions that go with this. You ready? Which of these TB drugs causes liver toxicity? All of them. So you can't ask a question about which of them causes liver toxicity if all of them do. The question is, what is different and unique? Which of them causes neurological problems? Isoniazid. Isoniazid. INH. I-neuro-H. Causes neurological problems. Which of them gives you red secretions, red urine, red contact lenses? Time for that red underwear you've been saving just for a special occasion. And that is red Fampin. It's benign. Just wear glasses, don't use contact lenses, or you will see the world through rose-colored glasses. Now, which of them causes eye problems? Optic neuritis. Which of them causes eye problems? It's the ethambutol. Ethambutol gives the eye problems. Optic neuritis. Now, what's the first part of the neurological system that goes? What's the first clue of the optic neuritis? It's loss of color vision. Color vision. How do you like my red and green top here? Well, how do you know it's the red and green top? Maybe you are colorblind and it is red and green and you can't see it. So you get color vision problems with the ethambutol. Last thing is pyrazinamide gives you hyperuricemia. A person comes in and they go on Rifamp, INH, PCA, and ethambutol, and they develop hyperuricemia at 6 weeks. What do you do? What do you do? Nothing. First of all, you're going to stop the pyrazinamide at 2 months, so don't do anything. Number 2, never treat an asymptomatic hyperuricemia. 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 They all can cause liver toxicity. They all, and remember, 5 times the upper limit of normal. Ooh, very good CCS case. Person comes in with fever, cough, and sputum. Acid-fast stain is positive. They go on 4 drugs. You advance the clock 1 month, 2 months. At the end of 1 month, 2 months, 3 months, the LFTs go up. Unless the LFTs are really high, don't do anything. Define really high. 5 times the upper limit of normal. Upper limit. That's a lot. Isoniazid, give B6, give B6. Isoniazid, give B6. Red-orange colored secretions, doesn't change anything. Doesn't matter, it's benign. And don't do anything about the hyperuricemia. Don't give allopurinol. And for ethambutol, just stop the medication. Optic neuritis, color vision problems. Now, 6 months, but is the standard length of therapy 4 drugs for the first 2 months, then 2 drugs for 4 months. 4 drugs for the first 2 months, then 2 drugs for the next 4 months. And now we finally get the kind of mathematics that medical students and residents can handle. 2 plus 4 equals 6. That is right. But when do we go longer than 6 months? Bone, osteomyelitis goes longer than 6 months. Brain, meningitis goes longer than 6 months. Miliary goes longer than 6 months. And pregnant, bone and brain and miliary pregnant. Bone and brain and miliary pregnant. Who goes longer than 6 months? And bone and brain and miliary pregnant. Cavitary has recently been added to that. You go longer if it's cavitary tuberculosis. There's more bugs in there to kill. Now, you will not be asked precisely how long there because it's not clear. All we know is it's longer than 6 months. HIV is not consistent for longer than 6 months. It's not. Now, latent tuberculosis means a person who's been exposed but has a very small likelihood of having TB. Now, that basically is PPD, is a positive test, latent tuberculosis. Now, the difficulty with PPD is that there's different cutoffs. We're glad cardiology is not like this. It's 1 millimeter of ST segment elevation unless you're near someone who's having a myocardial infarction, in which case it's a 0.5 millimeter of ST segment elevation. Unless you have no risk for a myocardial infarction, when it's 2 millimeters of ST segment elevation. You can see the problem with this test, right? It's a pain in the ass, right? 5 millimeters. For who? The biggest risk groups. For who? Close contacts. Are we close contacts for PPD? Well, how much contact do you need to be close contacts at PPD? A lot. Yeah, what's a lot mean? I'll give you an average. I once said this to the head of the TB program at Johns Hopkins. He wrote the national standards. I was at a meeting. And I go, well, how do you define close contact? And he goes, 4 hours a day for a week of contact. 4 hours a day for a week. You know that precisely? He goes, yes, it's in our policy. You made that up, didn't you? I did. I made it up. I had to publish a policy. It's like the hospital's like, we need a definition. So we figured, like, that's a good definition, so we made it up. Now everybody copies me, but I made it up. You're right, I made it up. But you know what? It gives you an example that how much contact you really need. 4 hours a day for at least a week. That means you, my friend, are not a close contact of your patients for 5 millimeter PPD. That's not how we round, that you're a close contact, 4 hours a day for a week. This is rounds in the hospital. How you doing? You feeling short of breath? Anything okay? You feel better? Do you need anything? Everything's fine? Okay, you'll be out soon. Thank you. The Hubble telescope has greater close contact with our patients than we do. We round from the doorway half the time. We are not close contacts with our patients, not for 5 millimeter PPDs. Close contacts mean household contacts with people in the same room. Steroid users, HIV positive people, that's 5 millimeters. 10 millimeters is in the general risk groups. 10 millimeters is in us, the people we love the most. Healthcare workers, HIV positive? No. But healthcare workers who are homeless, alcoholic immigrants, yes. 15 millimeters is a special thing. This is the pain in the ass about PPD. This is a really difficult thing because it's like, what do you mean you shouldn't test that group? People with no risks? Yeah, people with no risks, it's 15 millimeters. Yeah, but you just said don't test those people. That's true. Well, why are you giving me a cutoff for a positive for people I shouldn't have been testing? Don't disagree with me. I'm Conrad Fisher. I'm a very important person. You do what I tell you. I don't know why, but that's the answer. It's a fact. 15 millimeters is for people who have no risks, low pre-test likelihood. PPD, ooh, can you feel it? Ooh, look, I feel it. Ooh, it's rubbing. Yeah, the point is redness doesn't matter. What matters is induration. What matters is induration, not the redness. Induration, the raisedness, not the redness. The raisedness, not The redness. That's a question for step 3, because you can look at that stuff and you go, oh man, it's all red, it looks evil. Yeah, but if it's not bumpy, 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 it doesn't count. Now, if you've never been tested, let's say you're a person that comes from a country of high endemicity, or you had BCG as a kid, and you go, I've never been tested. Matter of fact, PPDs for us is a test to see whether I need a booster on my BCG. If you've never been tested, or it's been more than 2 years, and the first test is negative, you get a second test to make sure it's truly negative. The first test is negative. Make sure you get a second one to make sure it's truly negative. This is unique. Now, if you are a PGY3 medicine resident, this doesn't come up for you, because you should be getting tested every year. You should be getting tested every year. This is for people who've never been tested. You do a second test if the first one is negative, to prove that the first one was truly negative. What do you do if the first test is positive? When do you repeat the test if the first test is positive? When do you repeat that test? Never, 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 never. It's only if the first one is negative that you repeat it. If the first one is positive, never repeat it if the first one is positive. Now, interferon gamma release assay is an in vitro blood test to be able to tell the same information. There's only one point of difference between this and a PPD. What's the only point of difference? The only point of difference, besides it being more expensive, is that it doesn't cross-react with Bacille-Calmette-Guerin, which is the TB vaccination that's about 50% effective. It doesn't cross-react. So what's preferable to use in someone who'd been BCG'd? This is preferable to use if someone had been BCG'd. It's an in vitro test. It looks for latent tuberculosis, and its indication is the same in PPD, except it doesn't interfere, doesn't cross-react with BCG. What's the lifetime risk of developing TB with a positive PPD? 10% in your lifetime. 10% in your lifetime. That's it. You mean 90% of people with a positive PPD or interferon gamma release, 90% are never going to have TB? That's right. That doesn't seem like a very good test. It's not, man. Look, Robert Koch himself, who got the Nobel Prize for discovering the tubercle bacillus, he got another Nobel Prize for discovering anthrax. Robert Koch himself destroyed his career scientifically based on the PPD. He said that he had thought he'd found a vaccine. And he announced to the world's media that he had found the cure for the most common cause of death in the world at the time. And he announced it. I found it. It's a vaccine. It's called the PPD. He mistook the reactivity for protective immunity. And people have been making a mistake ever since. So what it is that 90% of people with a positive PPD will never develop tuberculosis. You're giving the INH for 9 months to clean up that 10%. Clean up that 10%. That's what you're giving the INH for. That's all you're giving the INH for. If the PPD is positive, the first thing is get a chest x-ray. If the chest x-ray shows an abnormality, get sputums. If the chest x-ray is abnormality, get a sputum. Make sure you didn't find early disease. And then what you do is, if it's positive, you'll give 4 drugs. But if it's negative, you give INH for 9 months. INH. The management for latent tuberculosis is INH alone for 9 months. INH for 9 months. But this is the biggie. The BCG has no effect on these recommendations. If you had BCG as a child and your PPD is greater than 10 millimeters and your x-ray is negative, even if your x-ray is negative, you need INH. I know what you're thinking. Oh, but I had a PPD when I came to work as a resident and they didn't offer me any INH. Well, they screwed it up. They should have. Oh, but they told me to get annual x-rays. Who gets annual x-rays? Nobody. Always wrong. Annual x-rays wrong. Annual x-rays wrong. Annual x-rays wrong. But they give me the PPD and I'm positive and they keep retesting me. No, it's wrong. Once it's positive, never repeat it. Once it's positive, never repeat it. Once the PPD is positive, never repeat it. Nobody gets annual x-rays. But I had BCG as a child. Eat your INH. But I had a booster of BCG when I was 17. Eat your INH. But I brushed my teeth every morning with BCG-flavored toothpaste. Eat your INH. I know what this comes down to. You don't want to take INH. So I'm going to tell you what happens. Every year or two in the United States, an international doctor comes to the United States, said, everywhere where I'm from is PPD positive. I don't need to take my ANH. And you know what happens? They work in the neonatal ICU. They expose children, kill small children. So take your INH. Thank you very much. And I'll take it too if I'm positive. Actually, I got myself a quantiferon this year myself because I just didn't want to make 2 trips to get the PPD read. So I did it for convenience. It tells the same information. And I'm happy to tell you it's negative. By the way, PSA is never right either. But I had mine done. It's normal too. Yes, it is. I'll see you in the next section.